Good evening, everyone. Myself, Dr. Srikanth, a pediatric neurologist from Rainbow Children Hospital. I will be moderating today's webinar. So thank you for being with us this evening. Today, we are pleased to welcome two very special guests to the webinar. Dr. Harish Jayaram, consultant pediatric surgeon and pediatric urologist from Rainbow Children Hospital, and Dr. Lokesh Lingappa, consultant pediatric neurologist. Our first speaker is Dr. Harish Jayaram. He is a consultant pediatric surgeon trained at PGI Chandigarh. He is a senior pediatric surgeon. His areas of interest is minimally invasive surgeries and has many life-saving bronchoscopic foreign body removal procedures to his credit. Inguinal scrotal issue is one of the common problems which we come across in day-to-day pediatric practice. With that, I ask that you pay full attention to Dr. Harish Jayaram and help me welcome to the webinar, Dr. Harish Jayaram.
Yeah, thank you, Srikanth, for the kind introduction. This is a very common office pediatric problem in children that we see frequently, even in pediatric surgical practice. And with a lot of implications for the parents. Parents are very concerned about this very common problem. It may be a common thing for us. For the parent, it is very difficult for them to subject a child with a problem like this for surgery. So there are a lot of issues which we need to address, and we need to know what exactly is this and what are we going to do about it. So the presentation is based, and the aim of the presentation is to discuss some practical issues. These are all. I'm not going into very the other issues, except that I'll be discussing on these practical issues about three common conditions. That's an inguinal hernia, hydrocele, undescended testes, and the related topics like the retractile and ectopic testes. Regarding this is based on the diagnosis, the investigation, and management only of these three conditions. And also, I'll be touching a little bit of the parental perceptions of these problems when they come to the hospital to meet a pediatric surgeon. The first case, I'll be discussing around 4 cases, and the first case is a 3-month-old male infant who was born term, a normal infant, and who presented with a left inguinoscrotal swelling appearing on and off. Parents have noticed this swelling appearing on and off since 2 weeks. On clinical examination in the OPD, I couldn't find any swelling, and the baby is crying, but I couldn't find any obvious swelling at all in this baby. And ultrasound was already done. The parents had got an ultrasound, and then they came to the clinic, and the ultrasound is normal. There was no evidence of any inguinal swelling at all. So there's no evidence of hernia in the ultrasound nor on the clinical examination. Now this is the 3-month-old infant. Now what next? There are several questions that come to my mind. Is the history very suggestive of inguinal hernia? If suggestive, is the history enough for offering surgery? Now, what else can be done? We have done an ultrasound, we've done a clinical examination. Can we confirm the presence of hernia? Is there any other way to confirm the presence of an inguinal hernia? If it is a hernia, is this the right time to operate? These are all common questions that come to the parents' mind, and we need to address all these questions. Can we wait? And if long, there are some issues. Parents will ask, can we wait? So if at all, for how long? And what about the contralateral hernia? Are we going to address the other? Parents need to understand that the other side also there's a potential hernia. So do we address it, or when do we address it? And finally, what kind of surgery? Now everyone is doing laparoscopy. So is it an open operation or laparoscopic operation? These are the questions that come to one's mind. I'd like to address it in a stepwise manner. Coming to the first question. History, yes, it is it's extremely suggestive that the history of any swelling coming on and off in the inguinal region is hernia, and no other condition mimics a hernia like this coming on and off in that area. So it's highly suggestive. Yes, it is suggestive of a left inguinal hernia. Now the second question. Is the history enough for offering surgery? The answer is yes and no. The reason is, in all these years and even now, most pediatric surgeons are pretty well convinced that this is enough to offer surgery. The history is very, very classical, and it is enough to offer surgery. And I've also been doing the same thing. But of late, parents are no, the issues are they are not very convinced about the just the history diagnosis. Basing a surgery based on only on history is a little bit odd for the parents. So I would like to confirm the presence of hernia by some means, and I'll come to that to the next point. So there is the answer is right now is we need to do something else other than just history to offer surgery for the parents. Now, what is that? The next question that we confirm is what else can be done to confirm the presence of hernia? Now, I ask parents, all of them have smartphones and all of them can record the event when it occurs. So I ask them to take a picture or record a video of the swelling when it comes. And most parents actually come with a video. Nowadays, parents are smart. They come with a video of the swelling when it comes and they show this is exactly how it looks when the baby cries. Right now, it's not there. Now that is enough. That is enough to say that okay, this is a hernia. Now, though we cannot see it at the in the outpatient clinic, but that video is or picture is suggestive that yes, this is a hernia. This is how the hernia looks, and this is a hernia. And the other thing is to rescan with a high probe, a high intensity probe. With a child crying or a vertical position, you can rescan and then we can document if at all it's there. But a picture or video is very confirmative of a inguinal hernia. The other question, next question, is this the right time to operate? The standard golden rule in inguinal hernia is we operate as soon as possible or the next operative list, next available operative list. That is what is the standard teaching that we all learn, and it is important that we operate and reiterate this to the parents, saying that it is important to operate as soon as possible to avoid complications, and that's what we tell the parents. Now, this how soon? How if we have a premature baby, if we have a very small baby with a lot of other risk factors, with respiratory issues, and preterm babies have a lot of chronic lung disease, and can they undergo a surgery for a hernia? Yes, it is possible because the incidence of complications is very high when the baby is the more premature and has more of respiratory issues. When the child is straining, the baby is straining, you have a high chance of incarceration and obstruction. So it is possible to operate, and nowadays we have very anesthetists who have very regional prone anesthesia, when they give a lot of regional anesthesia and avoid any opioids, avoid any kind of general anesthesia. In fact, we have a awake baby at the time of surgery when they give spinal cordal anesthesia to operate babies. It's a safe option to subject a preemie to a herniatomy operation at the time of discharge from the hospital. Next question: can we wait? And if so, for how long can we wait? Now, this is something, there are some, the older sibling is having his exams and there's a wedding in the family and a lot of social issues which come up, and the parents generally ask, can we wait? Can we wait? I tell them that yes, provided the parents understand the danger signs and can reach the hospital immediately. That is extremely important, telling them that this is a potential problem, there can be issues. It can be, and they should be able to come to the hospital in case of there's a problem, and provided that they can finish those issues and then sort out those issues and then come to the hospital. Now, the contralateral hernia and open laparoscopy, I'd like to dwell in a little bit of detail. There is a small incidence of contralateral hernia. Generally, it's around 7% and of contralateral hernia, more in girls and more in preemie. And these are the general rule that we have. The more premature they are, the more chances of the opposite side having a hernia. And left side, statistically speaking, left-sided hernias are more prone to develop the right-sided hernia. So this is a statistical information that we have. Now, coming to the important thing about question about this is a common discussion. A lot of discussion in the outpatient happens about open herniatomy and laparoscopic herniatomy in babies, and how do we counsel these parents about these two procedures? Yes, open herniatomy is a very standard procedure. It's been time tested. It's been used all over the world, and it's a very small incision, and it's a quick surgery without breaching the peritoneum. It's an external operation, and it is mostly done under regional anesthesia without the need to give a general anesthesia. So that's extremely advantageous points for an open herniatomy. Now, coming to laparoscopic herniatomy, what exactly is how does it differ, or what are the advantages and disadvantages of laparoscopic surgery? Very few centers in the world and in India offer a laparoscopic herniatomy for very small babies, and definitely the skill of the surgeon is extremely important. It's not an easy operation to do compared to an open operation, and it requires full general anesthesia, full endotracheal general anesthesia. The advantages of a lap over an open herniatomy, there are very few. The most important is the opposite side can be addressed, and as I said, the chances are less. Maybe we can see the opening, but it may not actually manifest. But once you're in, we see the opening. We can actually close both the holes, both the internal rings at the same time, and then and prevent another operation later on. As a surgeon, I'm very convinced that there is a very minimal handling of the vas and vessels in a lap hernia compared to an open hernia. Yes, we are very gentle even in open surgery. We just manage them, but still there's a theoretical risk that we do handle the vas and vessels in these small babies, and in lap we just dissect the peritoneum and close the hernia. And then finally the cosmesis, which are the 3 millimeter ports and a very small holes, and it's really not a big issue when it comes to laparoscopy and open herniatomy, because the open herniatomy scar is also very fine, very small, and then it is hidden in the groin with a almost invisible mark when the baby grows up. Now, this is a small video of how the internal ring looks when we have now this is a left. This is a left inguinal ring which is open, and that is how the internal ring is visible when we have a inguinal hernia from inside, and that is the ring that we close in inguinal hernia, in the repair of inguinal hernias. So that is how the ring looks how the ring looks from inside when we do an internal uh, repair of the inguinal hernia. Now, this is in contrast to what we saw the open ring. That is the closed ring. That is the closed ring that we see normally in any laparotomy. When you look inside, that's the vas entering into the closed ring. There's a vessel and there's a vas which is closed. This is perfectly sealed, normal internal ring that we see in non-hernia children, and compared to what we see in a hernia. Now let's come to another. This is another case. This is a child who came to the OPD, was 2.5-year-old boy. He came with a painless right testicular swelling since 1 month. Notice, since 1 month. Examination revealed a right thick transilluminant scrotal swelling. Now, this is a classical clinical diagnosis of a hydrocele. So we have a transilluminant swelling in a thing. Now, there's an interesting thing, like this transillumination. I do it for every child who comes with the scrotal swelling, because it's an ultrasound of the clinical ultrasound that we do it in, equivalent to an ultrasound to confirm that it's a fluid filled swelling compared to hernia and other things. There's an interesting thing that happened a few years ago when I saw the hernia, I could feel it. I knew, okay, this is a hydrocele. Absolutely, there's no doubt about this hydrocele. But the father had obviously had gone through Google and other things, and he said, "Sir, aren't you doing the transillumination test? Every clinician is supposed to do that. Aren't you doing that?" And that made me think that, okay, no, parents are very smart nowadays. We need to do the test in every child. So that's how I demonstrate to the parents. I do it myself, and then do this transillumination test in every child with a testicular swelling. Now, the questions that have come up to mind is, now, this is a clinical hydrocele. Definitely, there's a clinical hydrocele. So, is an ultrasound really necessary? Now, this is what we had discussion in the hernia also. Is a scan really necessary? And what is the ideal time to operate? He's 2.5 years old. Is this the time to operate on this child? And the other question is, now if you're waiting this hydrocele, we generally tell them, okay, it's fine to wait. So if you wait, can it turn into a hernia? And what about if you say it's just a water? So what are the long-term effects of untreated hydrocele? These are the questions that come to mind. Now, coming to the first question, is a scan necessary? Yeah, again, there is a small issues in these things that, yeah, most of the times you're right. Most of the times it's clinically, yes, it is a hydrocele. It can't be anything else. But it's important in these days and of evidence-based practice to rule out secondary cause. You can have an infection. It can be a epidermolysis with secondary hydrocele, or rarely a tumor tumor which can cause us. It could be a very small tumor. I had a child who walked in with the ultrasound with the clinical hydrocele, but the ultrasound showed a small area in the testis of a normal testis. The size of testis was normal, and the scan revealed a suspicious area of a hyperechoic region in the testis, which later turned out to be a Leydig cell tumor. And again, the parental perception. Again, they would like to have some kind of proof without for surgery, and that's the reason why I don't debate much nowadays. The parents saying that yes, a scan is necessary and it has to be. Now, then the next point: is this ideal time to operate? Yes, most hernias, statistically speaking, by around 1.5 to 2 years, generally, if the ring closes by that time, it closes. Beyond that, it is unlikely that the ring would close and the hydrocele would disappear. And by 2 years, we make a decision. This is a standard guideline all over the world. By 2 years, the hydroceles if they do not go away, then needs to be operated. Again, there's no emergency in a hydrocele, unlike in a hernia. So I give the choice to the parents to do it as whenever they're okay, but not postpone it by years together. Next question: can a hydrocele turn into a hernia? There are only 2 studies in the world which says that some hydrocele have turned into a hernia, and the incidence is between 0 and 5%. Yes, because the literature says yes, and we need to follow up this patient for a hernia if you're waiting on this. What are the long-term effects of untreated hydrocele? This is a recent paper from in 2020 recently, which studied a large number of patients with long-term hydrocele follow-up, and they have documented pressure changes in the testis, which due to the tense hydrocele, which can have issues in the fertility index later on in life. So this is a hydrocele, and the ideal age to operate is at beyond 2 years of age. So, and we need to rule out secondary causes of a hydrocele whenever we look at these children. The other 2 cases are basically undescended testes. They are interesting ones which I would like to discuss with these things. So we have an 11-month-old male infant who presented with an absent left testis. So it was an absent left testis, and the clinical examination showed there was no palpable testis. It was a left non-palpable testis on the left side. The ultrasound was done outside, and it showed a hypoechoic structure in the left inguinal region, suggestive of a left undescended testis in the inguinal region. So this is the ultrasound that came with the child when the child came to the OP. So this, again, the questions that arise in this case are: what next? Now, it's important to know the right way of palpation, because that is important to. It's an extremely important thing to differentiate a palpable and non-palpable, because the treatment depends, the type of management depends on whether we're able to palpate it or not. Now, the next question is it necessary for ultrasound scan or an CT or MRI to locate the testis? Is it the right time to operate? The baby is 11 months old. Is it the right time to operate? And how would I counsel the patients? And what is the algorithm for the management of undescended testis? Now, these are the things that we need to address when we deal with a baby with an undescended testis. So coming to the first point, this is the right time to the way to palpate. Now, there are 2 ways to palpate a testis, which on cursory examination, you do not find the testis. Now, we need to milk the region from inguinal region from the top to the bottom, and this is how it is done. So we need to press from above and try to milk the testis, which is there in the inguinal region, try to get it down, hold the hand on the top, and then try to feel for the testis. This is one way of doing it. The other way of doing it is to make the baby squat. When the baby is in the squatting position, the testis pops out of the inguinal ring, and then in the squatting position also it can be felt, and that's a clinical examination that's done in the OPD. Now, the other very controversial thing is it necessary for ultrasound scan for a testicular location? I would say no, and most pediatric surgeons would agree that there's no role for any imaging in the ultrasound scan. And then I convince my parents that there's no role for any imaging in an undescended testis, in a non-palpable or a palpable undescended testis. In a palpable, you can feel it, you know it is a testis, and you don't have to do any scanning. But in an undescended, in an intra-abdominal or a non-palpable testis, is there a role for imaging? I would say no. The reason is there are lots of false positives and false negatives in both ultrasound and in MRIs, and there are lymph nodes which are mistaken for a testes, and there are testes which is in the inguinal canal, which is commonly missed by all these scans. So there are a lot of issues in these things. I'll tell you what, I'll come to that later on when I discuss a case and show the findings of those cases. Now, that is a clear no from the imaging point of view. And even the parents, because of the false positives and false negatives, they're not convinced when you operate and tell them that there is no testes, or if you tell them that there is a testes, and then the scan said otherwise, and there are lots of arguments that go on once the surgery is done. The next question: is it the right time to operate? Yes, because the time to operate is between 6 months to 1 year, because most undescended testes would descend by 6 months if there is all the parameters are right for the descent, and they would descend by 6 months. If it doesn't descend by 6 months, they would never descend. So it's important that we operate. We wait up to 6 months, and some people operate around 4 to 5 months also. But 6 months is the reasonable time that we give for the descent to happen, and beyond that it doesn't. And beyond 1 year, the testicular damage is documented, and they have problems in fertilities when they grow up. So that ideal window to operate is between 6 months to 1 year, and the earlier we do it in that period, it's better. Now, the other question: how would I counsel the parents? Especially in a palpable testis is very easy. You can operate and find close it, and that's it. In a non-palpable testis, when the child we're not able to feel the testis, that is where we need to counsel the parents extremely well, that they understand the reasons and avoid problems in counseling after the surgery. So, how I counsel the parents for a non-palpable testis. Now, I tell them that the scanning is not indicated, and I would suggest a laparoscopy for a direct visualization of these things. And the possibilities on laparoscopy. This is very, very important that we discuss. The possibilities on laparoscopy are intra-abdominal testis. So most of them, I'll tell them that most of them, it is possible that we have an intra-abdominal testis, and some of them will have an atrophic testis, and some of them will have an absent testis. The atrophic testis and absent testis are relatively rare, but most of them we do find an intra-abdominal testis inside. And I also tell them that if there's a low testis, we finish off with a single stage orchiopexy, and if there's a high testis, it will require a Fowler-Stephens 2-stage procedure to get down the thing. So these 3 options are clearly explained to the parents before we subject the child for a laparoscopy, and most parents understand the nuances of this problem. Now, this is a laparoscopic finding of the same child. Now, this is the baby I said who's 11 months old, who came with a left undescended testis, our non-palpable testis. Now, when we do a laparoscopy, this is what we found, and this is what we did last week. And this is the baby who came to us last week. Now, this is the right ring which is closed, and this is the left ring which is also closed. So we have a normal finding inside. This is a non-palpable testis with a normal finding that vas and vessels are entering into the ring. And now this is the image of the same child. This is the area of interest where the left testis should have been somewhere inside, but we find that the vas and vessels have already exited the internal ring, and we are not able to palpate it. Now, this is an indication where we explore, and we could find a nubbin of tissue, a small atrophic testis in the scrotum, which was not actually palpable. And now with this findings, it is clear that we have atrophic testis. It's a confirmed atrophic testis, and I removed the testis, and we always remove the atrophic testis because of the theoretical risk of malignancy, and it is actually of no use, and we remove that. And then other issue in this child is, because this child has a testis in the scrotum which has atrophied, there is a possibility that this was an antenatal torsion. So, and the child already also has a single testis on the right side. So we fix the right side testis along with the orchidectomy that we do here. So it's important that we protect the testis, because there is a risk of this testis also undergoing torsion at some point of time. Hence, we fix this testis also. The last case is 8-month male infant who had a right absent testis. Now, the previous child had a left absent testis. This child has a right absent testis, and examination showed there's a non-palpable right-sided testis, and the ultrasound again showed a testicular structure in the inguinal region, somewhere there next to the bladder. It's a reasonable sized testis that was shown on the ultrasound. What did we find on laparoscopy? This is what we found on laparoscopy. There was a good sized testis, and this was a high testis. Now you can see this thing. We're trying, that's a testis. We're holding it, and it's not even coming near the ring. And the limiting factor for this is the testicular vessels. This child has a short testicular vessels, which is preventing the testis to come down. Now this is a high intra-abdominal testis, and this requires a two-stage procedure where we do a Fowler-Stephens. There's a technique called a Fowler-Stephens where we go and divide the testicular vessels. So this is what we do. We divide the testicular vessels, and that's how we divide the testicular vessels. And we cut off the main supply of the testis, blood supply of the testis, the main supply. And there are two alternate sources for the blood supply. One is from the gubernaculum and one is from the artery to the vas. These are alternate channels which enlarge over 6 months' time, and then 6 months later, we can safely get the testis down as a second stage after 6. So this is what we did the first stage recently, and this child will go for a second stage after 6 months. So this is about undescended testis that we had. We discussed an 8-month-old baby, 11-month-old baby with a left non-palpable which was atrophic, and this is a 8-month-old baby who had an intra-abdominal but high testis, high intra-abdominal testis, which we do a staged procedure. A word about retractile testis. It's a relatively common condition. It's actually more common than an undescended testis, and commonly mistaken for an undescended testis. And the clinical test, the only clinical test to confirm is a clinical thing where we get the testis. It is easily got down to the scrotum in a child who is reassured, quiet, lying down, and with warm hands. You gently get the testis down. It stays in the scrotum without tension, and this is one of the common things that we see when the ultrasound reported as a undescended testis, and they come directly for surgery for these babies, and we convince them that this is a retractile testis and does not require surgery. But a small percentage of them can have a secondary ascent. So these children need to be followed up until they completely descend. Or I've had children who had definitely had a retractile documented, and then later on, when they're around 8 years, 9 years, the testis definitely has ascended, and it's not coming down easily, and we had to do an orthopedic. So we cannot rule off surgery outright thing, that we need to follow these children, and then and surgery needs to be done whenever required. Finally, this is another child, very interesting. This is again, we saw this child last week. This child came with a non-palpable testis in the those testis which was not palpable, and there was a swelling at the root of the penis. This was an ectopic testis. An ectopic testis at the root of the penis, where we find that this is the testis which is exactly in the midline. And on exploration, yes, we did find the testis. We got it out. There was a big gubernaculum which had attached to the root of the penis, and which we divided and then fixed the testis in the normal scrotal sac. So this is an ectopic. There are many ways of, there are many areas of ectopic testis. The commonest being in the thigh, in the muscular plane. So these are all common things in the perineum. These are all things that we see in ectopic. So this is in short about the common inguinoscrotal issues in children, and the diagnosis and management that we do. So thank you very much for a patient hearing, and I'd like to answer any queries at the end of the talk later on. Thank you very much.
So thank you, sir, for your enlightening presentations. We appreciate for clarifying all the mysterious areas when which the parents do ask a lot of questions. And you have very clearly explained all the 5 areas of interest: the radiology, whether the scan is needed or not, the time of surgeries, the type of surgeries, what if we're not treated, what are the complications, and the counseling part. These are the basic 5 questions which the pediatricians have difficulty in answering the parents because it is a very important area of interest. So one question we have from Dr. Narayan, the role of HCG injection testis.
Okay. So this HCG, yeah, this hormonal treatment. There are lots of meta-analysis studies which have clearly indicated that in bilateral undescended testes there may be a role, and the success rate of these things are reported in a meta-analysis. The success rate is only 14%. And whenever there's a success, a significant number of them again reascend. So it appears that they have descended, and the hormonal therapy appears to be successful. But later on, it is found that they go back again. So most centers would not advise hormonal therapy for undescended testes. And there are recent reports of testicular damage following HCG injection. There are biopsy reports of these testes showing apoptosis of the spermatogonia, and hence, based on these findings, most pediatric surgeons would not offer hormonal therapy because the surgery is very simple, straightforward, get it down, fix it with minimal morbidity. We would offer a straightforward surgical option rather than hormonal therapy because of the 2 reasons, as I said, because of the complications of HCG, and in the success rate is pretty low. These are the 2 reasons.
Thank you, sir. The second question is from Dr. Rita. Can testis present as undescended testis as a child?
Yeah, that's what I answer. If I get the question right, can a retractile testis present as an undescended testis as a child grows? Is that right? Is that the question that is?
Yes, sir. Yes, the question.
Yeah, retractile. I touched upon that. Yes, and I said the percentage is extremely low, that it is less than 1% of the children land up as an undescended testis later on. We don't use the word undescended. We use the word ascended testis, secondary ascent. We have documented a retractile testis. That means a retractile is a descended testis and it's a physiological retraction. And later on, there's some fibrosis occurs and it ascends, secondary ascent. And that is the reason why we need to follow up these children, and at some point, if we document that it is truly undescended, then we fix it. That is what was.
Yes, sir. So there's a lot of listeners who are very happy with the presentation, sir. Please accept our sincere thanks, sir. Thank you.